Mesdames, Messieurs, bienvenue. Welcome to our panel on primary care financing models. I'm Yanick Labrie, an economist and health policy consultant. I'm honored to be the moderator to this panel. We are fortunate to have three excellent and distinguished panelists today with us, and I'll introduce them in a minute. They have all expertise in specific areas of healthcare. So let's begin with Gaby Bourbara is the president of AstraZeneca Canada, one of the world's leading biopharmaceutical company. He's a proven senior business and people leader with more than 22 years of experience in the Canadian, US, and global biopharmaceutical industry. Gaby recently joined AZ Canada after playing a key role as general manager in Canada with Alexion, AstraZeneca Rare Diseases Division. Gaby, welcome. Yeah, right there. Eva Villalba is the executive director of Coalition Priorité Cancer in Quebec, dedicated to improving Quebec's healthcare system for those affected by cancer. She holds degrees in psychology, applied linguistics from McGill University, and an MBA from HEC Montreal. She also holds a master's degree in value-based healthcare from Texas University, if I'm not mistaken. And she has a green belt certification from VBHC Center Europe, and is their official Canadian ambassador. Eva, welcome on stage. And last but not least, Dr. Alexander Singer is an associate professor in the Department of Family Medicine at the University of Manitoba, where he also serves as the Director of Research and Quality Improvement. In addition, he is the Director of the Manitoba Primary Care Research Network and a clinician teacher in Winnipeg, Manitoba. Dr. Singer. Oh, yeah, it's up to you. Okay. So the panel will be divided in three parts. First, I'd like to hear about each one of you, about your work, your area of expertise, which pertains to healthcare in general, and especially in particular in primary care. And then I'll move on to a second round of questions about the current challenges we're facing in primary care in Quebec, in Canada, and what type of solution we should implement, okay, to overcome those problems. So let's start right now. Okay, so Gaby, I'll start with you. AstraZeneca has been involved in the creation of a partnership for the sustainability and resilience of health system. Okay, a global initiative which involves also the London School of Economics and the World Forum. Okay, the Canadian report has identified 7 key areas, and funding is one of the main issues that we should address if we'd like to have a health system which is resilient. Could you first tell us a little bit about your organization, and then about this report and what's important? What are the key messages in this report?
Merci Yannick. Bonjour à tous, je suis très contente d'être à Montréal. Ça me donne l'occasion de parler un peu en français. Et c'est un grand plaisir d'être ici aujourd'hui pour discuter des enjeux de financement de nos systèmes de santé. AstraZeneca is a world-leading pharmaceutical company. We have innovative medicines across oncology, respiratory, cardiovascular, renal, metabolic, infectious, and rare diseases. Those great bits of science actually can't make it to patients in need if our system is not functioning the way it should be. And so we're motivated to partner with governments across the world. And Yanick mentioned it. We were motivated after the pandemic actually to start PHSSR, which is the Partnership for Health System Sustainability and Resilience. It's a partnership with the London School of Economics, with the World Economic Forum, with the World Health Organization, and it's across 30 countries. Here in Canada, we partnered with the University of Toronto, as well as with McGill and Université de Laval. And we have some real great opportunities to interact with multiple stakeholders, talking about how do we, partner to move the system forward in a sustainable fashion, in a state-of-the-art fashion, so that we can deliver better care for patients across Canada now and into the future. The great thing about being here in Quebec is with the transformation that's happening with Santé du Québec. Last September, there was a delegation of about 50 people that came together. Eva was there as well, in terms of looking at what does healthcare sustainability look like in Quebec, and what can we do together to partner on what that looks like. And there was many diverse views, but actually the team came together and really pushed forward a vision of where we want to go. And there was 10 recommendations. There was recommendations around health system and governance around the health system delivery, but then also financing the healthcare system. So maybe I'll just touch upon those two pieces in terms of financing of the healthcare system. The first piece was, there's a scarcity of resources. There's not resources to go around for everything. And so there needs to be a plan to put the resources where it's going to make the biggest difference and drive the greatest value. And primary care is the foundation of healthcare systems around the world and here in Quebec. And so looking kind of at a data-driven approach of how we can apply resources in the right way for primary care to deliver better outcomes for patients, but also create capacity within the healthcare system, was one of the recommendations that went forward. And an example is in Quebec, but also across Canada, with COPD, it's the number one reason for hospital admissions. Actually, number two after labor and delivery. But number one, if you're talking about kind of preventable hospitalizations. And what the Canadian Medical Association found out in a research study was, if there is a really sufficient connection at the primary care level and the secondary care level in taking care of respiratory disease, it leads to better patient outcomes and it leads to less hospital admissions. And so how do we think about applying that knowledge into a new and forward-looking healthcare system? The second recommendation in and around financing was looking at innovative networks and sharing kind of successes across, and looking at data to be kind of making our decisions for us and being agile with that thinking of a learning healthcare system. And I think Quebec has done a fantastic job with the GAP program, the Guide d'accès à la Première Ligne, otherwise known as GAP. And it really helps for those Quebecers who don't have a primary care physician to access care through different medical professionals for non-urgent matters. So again, we're not burdening the primary care system with kind of non-urgent matters, but patients are getting care and we're moving things forward. And so that's a great example of innovation that's happening here in Quebec that I think we need to build on and kind of grow as we move forward. So those are just a couple of examples, but we're excited to kind of have these conversations to identify new ways that we can move things forward.
Thank you, Gaby. Eva, I referred to you. Actually, when I introduced you, I said that you were the ambassador in Canada of value-based healthcare. And when we had the discussion prior to this panel, you said to me that you firmly believe Quebec's healthcare system has the potential to become a world leader in value-based healthcare. Can you tell us a little bit more about what is value-based healthcare? And go ahead.
Yeah, for sure. I think sometimes the word value is kind of thrown around very, very nonchalantly, and we have to kind of agree what that means, right? My other hat is I'm a patient advocate, right, for people affected by cancer. And so if we measure value as the improvement of health outcomes relative to the limited resources that we have to attain that outcome, then that's value. But that's not how we currently make decisions today. And so the reason why I think Quebec is optimally positioned is because we have a few things that were previously missing that now are advancing very rapidly. And Gaby mentioned it a little bit. That is, firstly, we were missing data. So in order to actually create value, what are we measuring today? We're measuring volume, we're measuring delays, we're measuring how much things cost us, but we're not measuring what we get for our money or what we get for all of the resources that we're spending. And so that's really, the gist of value-based healthcare. But in the literature, often people think that it's only hospital-centric, yes, there's a lot to do in hospitals, but I think that's why I'm happy to be here at Première Ligne en Santé, because actually the best way to obtain value for a population is to invest more in primary care, in prevention, in the rapport clair. So famously, we in Quebec love to do commissions, we love to do reports, and then they kind of, we say in French, they sleep on the shelf and like nobody does anything with them. We love to pay for that. But then recently in this health reform and in some of the work that the commissaire au bien-être de la santé, Joanne Castonguay, did, they brought back a lot of those really good recommendations and said, okay, are we ready to implement them? So in the rapport clair, they said most of the needs of the population are in prevention, and then chronic care, and then in acute. But the financing pyramid is actually inverted. We spent the most in acute care, then a little bit in chronic care, and then almost nothing in prevention. And we saw how that affected us. And I don't need to tell you all here who are interested in primary care how we need to invest, have the same pyramid, invest more in prevention and primary care. And that will actually lead to better outcomes for patients, because it's very expensive to treat people in an acute stage. It's much cheaper, but with our short-term view of cost and our current incentives, we're not incentivizing that. So basically, I'll sum it up as most of our problems come from misaligned incentives. Right now, with the pay for performance, the click-clack of the carte soleil, that really leads to poor incentives. It doesn't encourage interdisciplinary care, which I know we're going to talk about. It doesn't encourage measuring better health for patients. It just encourages giving more services. Do we all want an all-you-can-eat buffet of services? Do we all want surgeries? Who wants a colonoscopy? Anybody? No? Okay, we don't want services. What we want is health. We want to avoid using the healthcare system. And so what do we need to do? The data has to follow the patient. And now why Quebec is actually a bit advanced is because we have this new health data law, which, we all put a lot of hope in. Let's hope that it works so that the data can follow the patient. That's an essential element for value-based care. The care has to be integrated, not just at the hospital, but before, after, and during the hospitalization. So how can we actually integrate teams no matter where they are? There was a great value-based healthcare initiative from the Université de Laval and the CHU de Québec that actually is measuring now in Ontario, in Quebec, in 14 different centers, what is the relative value of emergency care, like emergency visits, outpatient clinics, and the GMF or primary care. And so that's going to be really interesting. And then how do we actually incentivize with funding to make people work together, to get the best outcomes for patients, and to actually make sure that we get the outcomes, but that the teams work together for that same common objective, which is value for patients.
Merci, Eva. Dr. Singer, you've published several papers and presented on a wide range of topics, among which is, and I quote directly from, you'll forgive me for that, but from your bio on your website, adherence to choosing wisely recommendations in primary care. So could you tell us more about this initiative and your research on this area, please?
Sure, absolutely. So I'll start by saying, so I also kind of wear multiple hats. I'm a family doctor 2 days of the week, and then I have my sort of research gig and do the work and sort of research and quality improvement the other time. And it sometimes spills over, and I bring a lot of the thinking that I apply to my research from my clinical practice. And one of the things in my early research work that I did was sort of help with the adoption of electronic medical records. And we thought that this was going to be sort of a panacea when we brought in electronic medical records. And very quickly, we concluded that we were using electronic paper records because we replicated all of the paper processes. We just threw it up on a computer screen. And instead of having pieces of paper, now I had scanned PDFs. And it frustrated me. And that's partly what motivated some of the work that I did. And the other thing that I think frustrated me early on in my career quite a bit was when we did something in medical practice that was unnecessary and then led to some harm with patients. And that kind of led me down the thinking of this sort of Choosing Wisely initiative. And the Choosing Wisely initiative is this concept that goes back to some of the roots in medicine from, back to the Hippocratic Oath of doing no harm. So the idea here is with Choosing Wisely is we need to be judicious about what tests and treatments we choose for patients. And as providers, we've got a lot of, as family docs in particular, but physicians in general have a lot of leeway about what things we choose. And there's not a lot of guardrails in our system that stop me from, say, over-ordering a particular test or offering a particular treatment. They're very much self-motivated. And so Choosing Wisely was, as an initiative, was started actually in the US, became an international organization a bit over a decade ago. And the Canadian group of Choosing Wisely has been really prolific in promoting it. And lots of great work has happened, and I've participated in a small amount of it. But conceptually, it's about limiting, reducing, hopefully eventually eliminating the parts of the types of care that ends up being unnecessary, that either doesn't benefit patients in terms of their health, or actually in many cases harms patients. So things like unnecessary blood testing, unnecessary investigations, unnecessary treatments. And in fact, I was just part of a soon to be released report. I think it's technically embargoed, so I can't tell you too much about it. But CADTH, the Canadian Agency for Drugs and Technology, and Choosing Wisely just prepared a report about minimum retesting intervals. And so this is the idea that if a test has been done in the not so distant past, it often doesn't need to be repeated. But what happens is, for various reasons, tests get repeated in our healthcare system all the time. And you can imagine there's many, many reasons. There's not a single silver bullet to this problem. But fundamentally, and I echo something Eva said, is the only way that we can constrain and better understand how to limit that unnecessary retesting. So the test has already been done. I'm just doing it a second time for no particular reason other than maybe I can't see the result. The result isn't available to me at the moment. I don't know necessarily that result exists even, or I think maybe it needs to be repeated, or it's too complicated for me to go retrieve and find that result. And until we actually connect the data within the system, that retesting will continue to happen. And for some tests, it's as high as 35% of the time the test is being done, or in the range of 30% of the time when an existing result is available that would be perfectly valid to use. And so the concept is, what are the things we can do to shift providers and practices away from doing the things that are really not adding to patient outcomes or population outcomes for sure, and increase cost, don't improve patient experience, and inevitably overburden the team. Because if I order unnecessary tests, I am the one that ends up reviewing them. And what are we living through right now in the crisis of access to primary care is that family physicians, primary care teams are saying, gosh, we're overburdened with administrative work. Part of that administrative work is some of the unnecessary care. And so if we can reduce 10% of the unnecessary care that is provided, that frees up resources. And when we think about equity, that means that we can put those resources into the places where it's actually needed, as opposed to repeating tests or ordering or doing treatments that don't improve outcomes. And so that to me has motivated me to do some of the work that I do. And I see that as part of the ecosystem within the idea of having a learning health system, because in a learning health system, we can learn from these things and we can constrain in some areas, but actually put more resources into the areas that really matter. And clearly, I agree with the panel that primary care is one of those places where you get really great value for the investment. And so that's why I think we need to really focus on primary care if we want a strong overall health system.
Thank you. Then we'll move on to a second round of questions pertaining specifically to current challenges in primary care in Quebec or in Canada as well, and to potential solutions to those challenges. So I'll start with a question, a general question, and feel free to answer. Whoever wants to start, it doesn't matter. And if you want to jump in afterwards, no problem either. So primary care in Quebec, as you know, is primarily funded on a fee-for-service basis, okay? And this funding system is often said to discourage collaboration with other professionals, and also to neglect the quality aspect of care. I don't know if you agree with that, but still, should we reform the funding system in primary care, and if so, how?
I could start.
When you start, I'll jump in with maybe an example.
Start with your example.
Start with my example.
Yeah,
okay.
Go ahead.
So fundamentally, when you think about fee for service, the payment structure is bum in seat. So I have to have the patient in front of me to see them. So that creates a provider-centric model. Mm-hmm. Whereas if we designed the system around the patient and we thought about what does a particular patient or a community need, we would probably organize the system quite differently. And that would support us using interprofessional teams, if we look at international examples, to achieve the best access for and having patients see the right provider at the right time. And if you think about primary care, the pyramid that you mentioned, there's the UK writes amazing reports too. Quebec is probably second best. So the Brits write the best reports. Sometimes they follow them even too. There was the Fuller report, or they called it the Fuller Stocktake, talks about primary care as providing three important aspects. So preventative care, chronic disease management, and then acute care for, symptomatic things. If you think about it in that framework, the physician is not always the best person to be the first person that the patient sees if they seek care. So if you think about preventative care, there's lots of preventative care things that the nurse on my team or the dietitian or the social worker can achieve that, for me, doesn't actually speak to my skill set. Whereas something related to a complex chronic disease management case that's actually what I'm trained to do. I'm actually not trained to be a social worker, and a good part of my day is spent being a social worker, but I work in a wonderful, well-resourced primary care team with an alternate funding model. And so I have access to those folks on the team. And that's not the typical fee-for-service model that, 2/3 to 3/4 of Canadians have sort of access to. And that's the people who have access to a primary care provider. The challenge we have now is, and this has been brewing for many years, this is a problem that's 2 or 3 decades in the making. We have lots of patients, citizens of the country, who don't have access to any primary care provider. And so I'm talking from the perspective of someone who works in a really well-resourced, wonderful team with a specific focus that, tries to target higher needs, complex, quote unquote, patients. And I think we do a reasonably good job of doing that in an interdisciplinary way in the clinic I work in. But then when I look at many of my colleagues' practices, it's disintegrated, siloed, and the payment function, the way the payment structure works, actually disincentivizes having a team, because if your team member, if a physician assistant or a nurse or a social worker sees a patient and does excellent care and provides really fantastic services, there's no way to pay for that in a fee-for-service model, because you're only paid for a single condition in a 15-minute time slot. And it's just that's not how primary care should work. And that's not how to design primary care to address those sort of three baskets that, many, many, many people from various reports have all said are the sort of cornerstones of primary care.
Absolutely. I would agree. And I think that, a few years ago in Quebec, we started giving additional kind of abilities, let's say, or the tâche, for pharmacists to be more involved and to do vaccination, for example, or, how do we better integrate nurses? So finally now in Quebec, we have that one of the ways that the minister has kind of tried to address this issue of access to primary care is you'll get access to a primary care team instead of necessarily a doctor. And I think that's an innovative kind of approach. We're going in the right direction, but then how do we fund teams? How do we actually incentivize teamwork? So I'll give you an example from the US, but from the public side. So in primary care, there's 2 examples, Oak Street Health and Eora Health. They both took on the most, the high flyers of the healthcare system, right? So like the frail elderly, and they were underserved. They were in like medical deserts, and they were ending up, it was the Pareto principle where like 20% was responsible for 80% of like emergency room visits. And they were able to say, okay, we're in French, we say like prise en charge. Okay. So we're going to like be in charge of a certain population. We're going to give you a bundled payment, a value-based payment, saying we're going to give you X, like whatever. I'm going to make up a number. Okay. Let's say it's 10K. Okay. For a patient, or 1,000. I don't even know the order of magnitude. Okay. But then you'll give that to the whole team. You just make sure that you address their prevention needs, their chronic care management, and you do everything as proactively as possible. We need to go towards a predict and prevent model instead of a break and fix model, which is what we have. And that's very expensive, and it's not sustainable, and it's not resilient, So what we really need is, I'll give you this much, you get the best outcomes possible. And then if you actually end up like using less resources, we'll keep the rest. That's an incentive to work together as a team. Okay. And so what they were able to do was actually to reduce emergency room hospitalizations for this vulnerable population by 43% in the Chicago area. Okay, so that's like a very concrete result. People were doing better. They were healthier. They were exercising more. They were socializing more. We need to go beyond like just, the ticking the box of like the clinical stuff too. We really need to ask like what outcomes matter to patients, what's the patient experience. And so there are really good models, but we need to incentivize that. And the other part that was missing traditionally, and you kind of alluded to it, is you have to be able to follow your patient whether or not they're in the hospital or in physiotherapy, for example, or in, they go to the community pharmacy and you don't know what they filled out. Like, we need the data to follow the patient. When they go to the hospital and they come back to you, you should be able to know what happened to them so that you can do a better follow-up. And I think that's what's been limiting us so far. And that's, I think, like what we need in order to tie those incentives to outcomes, and for all the team to want to work together towards that common objective of patient health.
Yeah, Yanick, is it okay?
Yep. Yeah.
Practice this, but can I ask a question of these two? Because in my role, you guys are the subject matter experts. I oversee kind of multiple elements of this, and we are trying to partner to, yes, screen and early diagnosis and prevent kind of these diseases, then move to guideline directed treatment. And I love your pyramid and it flipped upside down, right? So in a healthcare system, how do we make that change? Because it almost would be a double cost for a certain period of time, because you're still paying in the hospital, and now you're saying, wait, take some of that money and put it into primary care so that they don't make it to the hospital. But you can't. It's not that easy a flip.
Right.
Do you have any kind of research or examples from other systems that have made this flip, and how do they do it without breaking the system in the hospital?
So I think that it's easy to, be an ostrich and put our heads in the sand and like just continue to do the status quo, because we don't know how much it costs right now to have people be rehospitalized, to have people have complications, to do tests like way too many times. You guys at Choosing Wisely probably do have some data on that, right? But like we need to first cost out how much does it cost today? And then how much could it cost if we were to invest proactively with the right screening, with the right diagnostic testing, with the right, vaccination, for example? Like, how can we actually take that cost? But we don't even have the baseline yet. And I think that's like step one to improving financing is the data, but data of the funding tied to outcomes. What are we getting today for all of the money that we're investing and all of the resources? And we have limited resources. We have limited manpower, woman power, person power. How can we actually make sure that those resources, the right person is doing the right thing? But we can't do it unless we have a baseline. And we don't even have that. But in Quebec, we do have this new program called CPSS, Coût par parcours de soins. And we'll talk later about another program that's in place. But for now, it's just in the hospitals. In the next 5 years, it should start entering the primary care, and then we're going to have a better idea of how much things cost so that we can improve it.
So baseline data, and then
so I think data is a core element, and I'm a data geek. I mean, that's what my research is. So don't get me wrong. I think data is a core element. I think it's insufficient in the same way that co-location is not a team. So co-location is insufficient. You could have a team that functions very well, but is in multiple locations. So we need a few building blocks. And I think we need to transition and iterate. So fundamentally, I think we need a learning health system. Yeah. And there's some core elements. And if we had a learning health system in various areas within primary care, within the hospital, and then we start to tie those together and integrate them, we could get to the solutions that you're talking about. I don't think there's a silver bullet. If there was, it would have been done already. This is a complex, wicked problem. And so it needs multiple solutions, and those solutions need to be iterated. So we need the leadership and the governance of a learning health system, and we need the direction and the sort of clinical, I sometimes talk about when I'm teaching residents, clinical courage. You need to have a bit of courage to sort of say, I'm going to try this and follow up and see what the results are. That's what
we kind of talked about that at the start, right? Like it's kind of this test and learn, or having the agility, but the openness.
Exactly. And the openness and the governance and the leadership that supports a culture of curiosity and the fact that we know that we're learning, that it doesn't have to work the first time. So you need the governance, you need the actual human resources that can do this kind of work. So it's not just the clinicians. That's important and essential, but you also need the learning health system people to do the measurement and understand how to use it. You need that to be applied to sort of co-design, so that you're co-designing and iterating solutions, and that's baked into the delivery. We separate these things. I direct a quality improvement sort of platform. We teach residents how to do quality improvement, but it's largely disconnected from care delivery. And so we need to put care delivery and improvement and learning in the same bucket, and the data needs to support all that. If we kind of get that right, and we do those things all together, then you start to have a learning health system, and then we can iterate to get to where you're talking about, where we're shifting the resources. We also need to be able to shift the resources, because resources in healthcare are historically very tightly held. We couldn't pry the budget to pay for pagers out of the hospital system when we put everything on our cell phones. They wouldn't give up the $10 per person to pay for a pager. And this doesn't go back that many years. This goes back.
Don't get me started on the fax situation.
Right? But faxes and pages, we pay for those things. So we got to keep the fax contract going. We can't move that money away from the fax machines. Well, no, we have to take the money that we spend on paper and fax machines and put it into a server.
Yeah.
But that money has to get pried from the faxing department, and the director of the whatever, it's not actually a director of a fax machine, but we need to pry that money away and then redistribute. But there is a period of overlap. You can't invest without that period of overlap. It's like transitioning to electronic medical records. There was a period of time where we still pulled the paper, and then eventually we just stopped pulling the paper charts.
Yeah.
Well,
sorry,
I'm flying. You want to have?
I'm gonna build on that, just because that co-creation is really important with the people on the ground responsible for implementing it, but also I have to say also with patients, right? With patients and the population and the people that will ultimately be affected, because traditionally we've always ask doctors, what do you think your patients need? And, we don't need to do that anymore. We're in 2024. I invite you all to actually ask your patients. It's crazy. It doesn't cost anything. But also it gives better results because you're really responding to the needs of the population. And the population does not want an all-you-can-eat buffet. So they're not going to want all of the most expensive, fancy things if you explain it to them properly. So that's where the informed consent comes in and is really important. But the other part that I wanted to touch on that you mentioned is the psychological safety of making that shift, because it is a paradigm shift to work together, to be transparent about results. So one of the things that I think Quebec did pretty well is during the pandemic, we had these dashboards. Now we're continuing with these public facing dashboards. We need to actually give ourselves permission to have this learning health system to okay, it's not going to be perfect right away. We might evaluate the baseline costs and be that's bad. We could do better than this. But we need to give ourselves the psychological safety to actually be transparent and to learn together and to move in that direction. And without that transparency, we can't move ahead. Famously in Quebec, it took us 14 years to have a Quebec cancer registry because we were waiting for perfection. So we can't let perfection be the enemy of the good. We actually have to say, look, we're not, these are our results. They're not amazing. Now on our public facing ministry dashboard, there are red elements, right? How many people have access to primary care. It's not always green. We're still far from the objective, but we need to give ourselves that kind of space to say, it's okay. We're learning. We're co-creating with all of the actors, everyone who's here, everyone who's not in the room, and how do we actually go in that direction together? But saying that it's okay if it's not perfect today, we need to agree on what the objective is.
Yeah, totally agree.
Well said. My next question fits, I think, perfectly in this discussion. In a discussion prior to the panel, one of you mentioned that, I don't remember who, mentioned that we got to get rid of this silo mentality. Perhaps it's Dr. Singer, because you alluded to it.
I say that often.
Previously. And we have to adopt a more integrated approach. Well, in terms of integration, what can we do better to to integrate primary care in the rest of the healthcare system in Quebec?
So let me just give you a very simple but super complex clinical example. I saw a patient, it wasn't yesterday, it was last week, who had a limb amputation after being in hospital, having had a lower limb ulcer. Okay. So this is someone that home care had been working with for probably a decade. So maybe that person unfortunately had a terrible outcome, but probably had that outcome based on some pretty decent team-based care, probably about a decade later than some other patients. Walk into the hospital, you see, and in Manitoba is among the worst for the statistic of younger people getting lower limb amputations. Crazy complex problem, lots of inputs, and did that person have a lower limb amputation because I did a terrible job as their family doctor, or did they have it because they had a whole bunch of complicated things happening in their lives? One of my colleagues once described family medicine as like, it's not like throwing rocks, it's like throwing birds. So you can only do so much, right? But at the same time, we know in the hospital system, patients with lower limb amputations are among the highest cost, most complex, and the reasons are diverse. So now I saw that patient coming out of the hospital with their lower limb amputation. I knew the whole story because I'd been looking after them for, a long time. I didn't have a discharge summary. So I'm following up on their care, and I'm being asked to follow up on this post-operative care without a discharge summary. It's unconscionable. It's unconscionable. I got on a plane yesterday. The pilot had the manual. They didn't ask the pilot to, oh, this is a Boeing. I know you usually fly Airbuses, but we're going to get you to fly the Boeing today. Like, it's insane. Now, I happen to have a relationship with this patient. I knew them. I knew where this was going. We had been looking after the wound for a long time, so I had some history. I had some knowledge. If that patient had showed up at a walk-in clinic, because 1 in 5 Canadians don't have a family doctor, and frankly, the majority of patients who are having lower limb amputations are the ones who are falling through those cracks. If they had shown up at a walk-in clinic, no discharge summary. What's the walk-in doctor supposed to do? How does that person manage? It's next to impossible. And so the data systems need to support the patient care, and we need to have the kinds of systems that can prevent a lower limb amputation, even if they're going to happen, but that prevent that kind of thing from happening and try to deal with the antecedent causes, like diabetes and hypertension and poverty. And we need to stop treating poverty with limb amputations and dialysis and actually deal with it a decade or two earlier and put in the health interventions. But that's complex and problematic, and some of the problems that leads to these things aren't necessarily healthcare problems. I'm not a bad family doctor because one of my patients had an amputation. I did the best I could.
I also think that our system is historically like very hospital centric. And so, I can't get the family doctor, I'm just going to go to the emergency room, and then that creates all these problems. But if we actually enabled, better home care, better care in the community, better handoffs, like you said, between the hospital discharge and the primary care physician, or even if it was, what we advocated for here in Quebec is that the data has to follow the patient, the data has to belong to the patient. And if the data belongs to the patient can share it with whatever healthcare provider is taking care of them. And that's, based on consent. So I think until we can do that, there won't be that continuity of care, that integration of care. And historically, the primary care has been so siloed, and because of the funding models that were also so different, there is no incentive to actually collaborate, even though ultimately, like, what is our health system for? Is it a healthcare system or a sick care system? Currently, we can't really say with confidence that it's giving us health. All we're measuring is, illness, kind of. We're measuring more volume of services, right? So how do we do that? I think we have to integrate the before, the after, the during, and that goes through, yes, data, but more importantly, how do we incentivize it with a better funding model? And I think we are going a little bit in that direction.
And you need to link those two things, right? So the funding to break those silos and create a data ecosystem that surrounds the patient as opposed to the clinic, like instead of a provider-centric model, that needs to be paired with the kind of system design that then creates a functioning team so that there is a warm handoff, and that that my clinic that's literally physically next to a hospital can coordinate better with a hospital, right? In a way that is not we've designed the system in a way that is really focused around hospitals, and that that's a historical sort of hallmark of the particularly the Canadian system is we fund hospitals, and then the add-on of primary care was sort of an afterthought. We never finished the job of healthcare. Like the original sort of Tommy Douglas plan, we did healthcare part 1. There was a part 2 that never got funded and never actually saw the light of day for various political reasons in the 80s. But and there's been a dozen reports since, from Romano to the Pan-Canadian Health Data Strategy, that have all said we need to integrate and break down silos and all this kind of things. We just never got there. We still haven't achieved it yet.
And even, you mentioned before the choosing wisely with the repeated blood tests. Like I've heard that from doctors. They just tell me it's so hard to get this data that I'm just going to ask for the test again in my own hospital, and then I'm going to actually have it today.
Right.
Why? Because I mean, there's an incentive for that. How can we actually disincentivize that and incentivize, like, create this ability to go and get that data? I think the data following, and that's not the issue today, but I think that the reason we can't do better financing is because we lack that data. But that's again why I think that Quebec is a little bit advanced, because although there's the pan-Canadian health data strategy, the reality is even within a hospital, even within health systems, we're still working on this. And with the new health data law here, we're hoping that there's going to be a little bit more transportability and interoperability of data that will allow us to do that. But we still need to measure those baseline costs.
The silos themselves are not technological problems. They're problems of policy and design.
Yeah.
We've designed it this way. It's not that we can't share the data. You can share banking information just fine. I can walk across the street, take out money from any ATM from any bank.
Yeah.
So there are solutions out there. We just haven't designed the system around an interoperability lens.
Yeah.
We've designed it around institutional lens, and we need to shift that. That's how you get away from the silos, is by moving away from sort of a focus of institution here, and that's all I care about is my clinic or my hospital, to the whole population, and then breaking that down into communities and then patients sort of at those levels.
And it's preventing best clinical practice, because it's just bureaucratic barriers, not clinical.
Right. It's not a gap in knowledge of what to do in terms of, should I talk to the vascular surgeon? Of course I should talk to the Should I get the records from the vascular surgeon? Of course I should. But how do I get them, and how does that come to me without it being a fax? Or how do I retrieve them on a provincial system if I need them, so that I'm not overburdened with a million pieces of paper or data points that come to me, but I can retrieve them when I need them? That's a design issue. And you can design a retrieval system. When I show up to the bank to ask the teller what is in my account, they don't have to go to the back and get a piece of paper or call the bank down the street to get it faxed over.
Yep.
Well, thanks. I've got one last question before we open up the floor to the audience. And this one's for Gaby, because I know that a few keywords today: collaboration, integration, value-based healthcare, resilience as well. Gaby alluded to that in his introductory remarks. What should we do to make our healthcare system more resilient? Do you have any idea about what we should do?
Yeah, so I think these conversations are a start, right? I think the group we brought together in September here in Montreal is another step forward. The recommendations that actually came out of that went as an action plan to Minister Dubé, and he was very thankful for that, right? So I think there's opportunities to kind of action what has been recommended, what experts kind of came together. And similar to Alex's point, as well as Eva's point, we have to act our way into this. It's not going to be perfect. It's not going to be easy. There's going to be barriers along the way, but I think, it's progress over perfection.
Yep.
And so how do we make that progress? And so the role, that we play as AstraZeneca Canada or as the industry is we want to bring those partners together to have those conversations. We want to propose collectively and co-create kind of what are some potential avenues to do this, right? Because we can develop the best medicines that exist to human race, but if there isn't a system to absorb them and to work with them and to get them to patients, then it falls down and patient outcomes aren't what they want to be, and systems start to break down. And all of us are Canadians. We want to get good health care, and we want to kind of receive it. And so I think those are the elements. What I would say is, what does resilience mean? It's actually, not only for the healthcare system. I think we need to be resilient as we step through these kind of processes of change and agility and kind of testing and learning, and then using data to make data-driven decisions on what step 2 is and step 3 is, and how do we integrate. And I know it's easy to say and hard to do, but we need to, as much as we can, remove the bureaucracy from things. And it's not easy, I know, but we're not going to move things forward. And I'll finish with this. I've lived in multiple countries, and there's this perspective that Canada has a fantastic healthcare system. Oh, you're from Canada? Healthcare is amazing. It's like, it's okay. No, honestly, it's okay. And that's not good enough. Like we can be better. And I'm hopeful with some of the stuff that's coming out of Quebec and the province here, and the thinking of a learning kind of healthcare system, that we can start to move it forward in Manitoba and Ontario, across the country, because it's going to be up to us. There's no one else is fixing this. It's not one person's job. I think it's all of us to come together.
That's a good way of summing things up. Well, now it's your turn. If you'd like to ask questions to our panelists, you can walk up to the microphone. I think there are microphones somewhere. No?
Probably just holler.
Oh,
we can probably
we have a mic right there. It could be in French as well. Vous pouvez les poser en français. Eva's gonna translate.
Yeah. Monsieur, vous pouvez amener le micro, s'il vous plaît? Non.
Oui. Oh.
For the translation, I think avec le micro, c'est mieux.
Or maybe you can repeat it back.
Yeah, I could do that.
Depends how fast you talk.
Check.
Yeah.
Oui.
I speak a solid franglais.
Alexander, you talked about a learning, like you have to be having people part of the team that are going to be learning, like a learning system. How would you, I have a feeling I don't want to argue with you. On the contrary, how do you make it from people that are learning in the team, but everybody's got to be part of this learning system, because everyone has to evolve in their way of thinking. How do you implement that culture? Because you seem to have succeeded in doing it in your clinic.
So I had a small success in my clinic. I would say I started my practice in a clinic just up the road that I would describe as a very high functioning team, because everything happened collaboratively. And then I moved to a different practice in Winnipeg that was similarly. I was just lucky to have joined a team that we met regularly, we discussed problems, we dealt with challenges, and we had a structure baked into the actual clinical operation to deal with complex cases and also teach, in part because one of our jobs was teaching residents. And then I joined a new practice a couple of years ago, and it was completely disintegrated. We actually were co-located, but functioned as independent silos. And one of the things I did when I first joined was that we need to start to figure out, how do we create a better team-based environment? And there's lots of different examples sort of internationally. So in primary care, probably my favorite, or I think the model that works, that is one of the most successful, was actually developed, refined in Alaska. It's called the NUCA model. It involves sort of moving a large primary care team into smaller micro teams. And so you have a smaller grouping within a bigger team, and then you share some of the other resources. So we have a pharmacist, an occupational therapist, a physiotherapist, and a social worker. Those people are resources to the whole team. And then we have 3 micro teams, all composed of 2 to 5 physicians, depending on how big a practice. Like, I only work half time, or 30% of the time, and I share my practice. So 2 of us plus 2 other practices, we share a nurse. So 3 full practices share 1 nurse and 3 administrative assistants. And we have a cohort of patients that we look after as a micro team within a bigger team. And then we can meet, and then we often meet with our social worker or occupational therapist about a complex particular patient. And within our smaller team, we interact and look after that group of patients. So sometimes if you call my office today to speak to me, I'm not there, you're going to speak to the nurse. And the nurse will speak to patients within 24 hours, usually within 1 or 2 hours. And can't be booked with me, I'm not here today, well, you can see one of my colleagues. Is it not emergency? You just want to see Dr. Singer in whenever? Okay, we'll book it next week when he's back. So there are ways to organize even within teams. The challenging part is transition. So often there are team members who are very resistant to the kind of changes to sort of reorganize, and talking about an individual team. To reorganize the team, you get often lots of resistance. And classically, I don't want in any way to take this as a bash on primary care nurses. They're wonderful people, and I love many of them. I really appreciate the nurse that I work with. The nurses are often very resistant. They don't like this idea. They do their work, they have a protocol, they follow it, they don't want to change it. If you bring those people into the transition group, the resistors, often you get the best ideas, because the reasons why they're worried about changing are all of the things you need to address. Yeah. And then inevitably, and I can speak from my own team's experience, our nurses are the biggest champions.
Yep.
They talk about the micro team model as wonderful. They think everybody should do it. They're telling other nurses in other clinics, you got to reorganize your clinic to work this way. But it took time and energy and effort and a sort of repeated agreement that here are our goals.
Yep.
Our objectives are better patient, better panel management, better population community care, better patient experience, keeping our costs at least neutral. We didn't have new money to spend, so we had to deal with it with the funding that we had. And then the team experience. And then we thought about, so those are the 4 sort of principles of the quadruple aim, sort of, because you can't do it if the team's not happy. If everyone is furious, you got to get people on board. And then the final thing is, how do we distribute our resources then equitably? How do we place the most attention to the people in our practice, our community, who need it the most? And if you can do that, if you agree on those goals and you agree on where you're aiming to go, it becomes a bit easier to get things moving. And it needs to happen sort of at the local teams. And then but they also need the resources. If your local team is only a doctor and an administrative assistant, well, how do you pair that with other resources and compose maybe a distributed team? There are other models. The one I work in is designed for a particular sort of output, but there are other models. But the transition is difficult. So that's the best I can tell you.
I think the main ingredient is having the leader to bring the vision and making sure it happens.
Absolutely. Absolutely. Couldn't have done it without our clinic manager saying, we're going to do this, come hell or high water kind of thing.
But also the co-creation that you were talking about, and that's like the change management aspect that we neglect way too often. So anytime, and even when you're doing great work, you can do great work in your clinic, but how do you actually make that scale to like the rest of Manitoba? Or now you're giving us ideas in Quebec. Thank you very much.
Right.
But there's that psychological safety that I was talking about, the communication with your team, agreeing on a common vision, on a common goal. But that co-design of getting even the resistors on board, that's what really makes it sustainable and impactful. And
I forgot to say one thing, and I'll be really quick. The other part about what made it work was deconstructing the co-creation from I do this is my role, to here's a patient, here's an example. And we borrowed this from sort of the world of marketing. So the industry people in the room will probably appreciate this. We created patient personas and we use those to drive the co-creation. We said, here's Jim. He's a diabetic who lives in the local homeless shelter. And he comes to the practice for an unscheduled visit because his sugars were high. How do we look after Jim?
Yeah.
And then we thought about how the clinic operates and should operate based on a series of patient personas that previously we had agreed that kind of look like the kinds of patients we serve. And so we created a series of personas that were not true people, but representative of our community and what sort of our defined population. And so by doing that, it takes away a little bit of the siloed thinking of like, well, I'm a nurse, I answer the phone and I do immunizations or whatever, to, oh, well, I'm here and I'm doing immunizations and I can always take a minute out to speak to Jim and figure out when he needs his appointment. And it shifts the thinking, and it's really effective, I think, both in teams, but also within communities. Yeah. You bring people together around a co-design principle of, let's design this around, here are these patients, and you give them a story, and suddenly the barriers break down. We did this around immunization planning during the pandemic, and it worked beautifully. But we just need to do more of it.
Yeah, can I just add?
Yeah.
Here, yes. No. I what I loved about that is co-design, right? Which is one piece. But the clarity on goals.
Yeah.
Right. And you didn't say it, but I wonder if you know of this. But in the UK, they have clarity on kind of what are the goals in practice, and then there's incentives tied to that.
Exactly.
Right. So it's like, this is what I do, and this is how I get rewarded for what I do. And so like that's another kind of idea, and I think you were speaking to it. Like, what are the incentives? What's the value we're driving here?
Yep.
And then how do we tie that to incentives? And then how do we use data to measure how we're doing, and really drive those.
And the common objective being increasing value for patients.
Right.
How do we do that?
It's inevitably tricky to define what we mean sometimes by value, and that's where there's a tricky conversation, because outcomes and value and care versus outcomes are not always the same thing. And if we pay just for outcomes, we can miss the mark, because sometimes what drives poor outcomes is not bad care.
Yeah.
So we need to shift some of the thinking to provide care and think of our value as service providers. We're providing a service. We can't guarantee that the service is going to be successful, quote unquote. We can't prevent every complication, but we can aim to. And if we do that, we'll prevent most of the complications,
Yeah.
but not all.
That's where you have to tie in a little bit of wiggle room and like risk, you know. But I think
Right.
there's another
Sorry.
question.
I hate to be the one standing between us and lunch, so I'll try and keep it quick. We've talked a lot about measuring value, cost, outcomes, for example. I'm wondering if you have thoughts on what the most impactful or the most impactful measures, like what the unit might be. So are we talking about at the individual level, at the community level, at the regional level, at a population level, and where, in primary care might potentially different units play different roles in convincing certain decision makers around flipping that pyramid of investment?
Definitely, depending on the patient segment and the disease area that you're looking at, there are population level indicators. There are individual patient indicators. So we can't just use one measure for everything. So
Right.
I think that's the basic thing, is we can't just measure one indicator for everything and then tap ourselves on the shoulder because we're doing well. We really have to understand at the population, at the patient segment level, that disease area. The problem is now that we're addressing it too much by in hospitals, it's by medical specialty or by organ. No, it's let's take COPD or diabetes, and then how do we treat those people? What kind of different patient populations are there within even diabetes? There's different, type 1 versus type 2 versus some social determinants of health that really
Incredible
change the
spectrum.
outcomes.
Yeah.
So by adapting, and one of the ways to do that is by collecting patient reported outcomes. Yes, we're already collecting clinical stuff in a very fragmented way, but how can we actually help the patients report on their outcomes and their quality of life, so that when they do meet with the doctor, it's a much more efficient meeting, and they can actually target what is specific to them and not their neighbor. That's
And
my 2 cents.
some of the indicators are extremely hard to measure. So relationship, okay? This is my classic example. The relationship that a family doctor has with their patient or a primary care team has with their community of patients is incredibly powerful, but incredibly hard to measure. But it matters. And we know it matters. There's lots of good data that shows that patients who have a strong relationship with their primary care provider, family doc, or team, they have better outcomes. Why do they have better outcomes? Because there's some accountability, there's some knowledge, there's a comfort level. If your neighbor or your family member is a family doctor, you get better care because they'll help you navigate the system. And my patients who I have a good relationship with, some of them, are friends and neighbors, and some of them are just random community members. But I have a relationship with them, and so I care, and they care, and there's a mutualness to it. It's very hard to measure that relationship. You survey my patients, I don't know what they'd say. Maybe they, but there is a real benefit, and there's a real value to that. So getting the indicators right and having a suite of indicators as opposed to focusing on one outcome at the expense of another, sort of thinking about the balance measures. If I spend all my time worrying about diabetes, what are the things that I'm not worrying about? Yeah. It becomes very hard, and primary care, like other parts of the health system, are complex, and we don't operate within organs, but things do tend to cluster.
Yeah.
Right? The same patients who are at risk of diabetic complications are also the same patients who are at risk of heart disease and stroke and a whole suite of other things. And similarly in the respiratory kind of clusters. So we need to start thinking more effectively about the suite of measurements, I think.
Absolutely.
Well, do we have time for a last question?
And we promise not to ramble.
Yeah. Like to ask? No?
If not, maybe I'll add one more thing that we were going to talk about, which is in Quebec, we have this FAP, this financement axé sur le patient, or patient-based financing. It's a step in the right direction. For now, it's just in the hospitals, and it's really more like a bundle for an episode of care, not the whole, trajectory of care like we would like. But there is a plan within the next 5 years to actually take that to, pre-hospitalization, post-hospitalization, ambulances, services like that. And I think that type of approach, more longitudinally, more, interprofessionally, that type of financing is really what's going to help us, rethink the financing model and actually encourage a team-based approach, encourage, getting the best outcomes for patients. I think that type of patient-based funding, which is not activity-based funding, is really one of the tools that we need in order to, create value and resilience and sustainability in our healthcare system.
Yeah, when you describe it that way, you can sort of see the alignment.
Yep.
And then, of course, the devil's in the details, right? Do we do it for one condition or one group of conditions, right? Like, pharmacare is going to cover diabetes medications. Well, really, it should cover a whole suite of medications. So how do we get the funding right to match up,
Yep.
Appropriately? It's tricky.
Yep.
It's going to take lots of iterations, I think.
Yeah.
Well, excellent timing. Hey, thanks for your presence first, and thank you for our panelists. Really appreciate it. Right.
Thanks, everyone.
Thank you.